Hello friends, today we are going to discuss about electroconvulsive therapy in geriatric population. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neuroscience, Bangalore. In this video, I'll be discussing about what is the prevalence of psychiatric illness in geriatric population. Can we give electroconvulsive therapy for this geriatric population? What are the side effects and precautions to be taken before you administer electroconvulsive therapy? Let's understand what is the prevalence of psychiatric illness in geriatric population. There are various studies across the globe which clearly have said that psychiatric morbidity increases with age. That means the number of people who are going to suffer from mental illness increases with the age. And the studies have said that the prevalence of psychiatric illness in geriatric population, that is around 40 to 55%. Here geriatric means above 60 years. And when compared to non-geriatric population, the prevalence of psychiatric illness is around 10 to 15%. That means geriatric population has the risk of developing psychiatric illness is 3 times. In normal population, it is around 10 to 15%, whereas in geriatric population, it is somewhere around 40 to 55%. The common mental disorders seen in geriatric population are depression, dementia, mood disorder, anxiety disorder, personality disorders, drug and alcohol abuse, delirium, and psychosis. If you look at the prevalence of psychiatric illness, a study was published in India. This is a study which is titled as Prevalence of Mental Illness and Their Association with Socio-Demographic Factors in Rural Geriatric Population in Chittoor, Andhra Pradesh. It is a community-based study. This article was published in Journal of Education and Health Promotion and published in 2018. Let's look into the results of the study. Since this is a community-based study, they were able to estimate the prevalence. The prevalence of psychiatric illness in geriatric population was 52%. That means half of the senior citizens had one or the other diagnosable psychiatric condition. This was in a rural population, my dear friends. Let's look into various psychiatric illness which were diagnosed. The most common was the depression. It was around 27%. Anxiety disorder 7%. Dementia was 14%, my dear friends. And further, if you look at the cognitive impairment, the percentage with mild impairment was 27%, moderate impairment was 12%, and severely impaired was 7%. But what I would like to emphasize here is 50% of them had one or the other psychiatric illness. Let's look into the global prevalence of depression in elderly population. Here, we are focusing only on depression because depression being commonest in Indian population in a rural study. Let's see how does it compare with the international study. This was published in 2023 in Asian Journal of Psychiatry. It is a systematic review and a meta-analysis of epidemiological survey. Here, this study took into consideration of 55 studies which looked into the epidemiology of depression. This encompassed 59,851 individuals and met the study criteria and were included for analysis. The overall prevalence of depression was 35%. That means 1/3 of the older population, that means 1/3 of the senior citizens are suffering from depression, my dear friends. Similarly, the prevalence of dementia, which was studied in India, let's look into the systematic review and meta-analysis. This was published in Indian Journal of Public Health in 2021. Here, the present meta-analysis which was done included 20 epidemiological studies which encompassed 86,312 persons. The result indicated the prevalence of dementia in India was 20 per thousand, that is 2%, my dear friends. Let's look into the total burden of dementia in India. We have approximately 14 crore senior citizens. Here, senior citizens means 60 and above is the population. In that, 50% of them have psychiatric illness, that is around 7 crore. And if you look at the people who are depressed, that is 35% in senior citizens, that amounts to approximately 4 crore. And 2% of them have dementia, that is 2 to 3 million of them have dementia, that is somewhere around 25 to 30 lakh people are suffering from dementia. These numbers are huge from public health perspective. Why does that matter? It's simple. Imagine it is not just a person with senior citizens suffering from mental illness. Imagine depression, dementia. If one person is there in the family, the whole family will suffer. That means the burden of this mental illness in senior citizen is very difficult to quantify. It will tear apart the whole family. And the person who is providing caregiver will go into depression, my dear friends. There are various studies which looked into the caregiver's burden. What do you mean by caregiver burden? It is providing care for the senior citizens with mental illness is a full-time job. It is not that you provide a care for half an hour and walk away. It is like looking after a small child. That means you'll be investing emotions, you'll be physically doing a lot of activities, you need to quit your job, and it is a full-time job to take care of your senior citizen at home. And if you look at these studies which was published in 2022, a review article, in this review article they looked into suicidal risk in the caregiver of people with dementia. This is a systematic review and a meta-analysis. What did this say? Caregiver burden is well known in dementia. The prevalence of suicidal ideation in this meta-analysis, which was clearly said that 32% of the caregivers has suicidal ideation. And in this study, they looked into the two studies which reported the suicidal attempt were around 6 to 16% in caregivers of dementia, my dear friends. And 1 in 17 caregivers death by suicide. Think about it. Dementia does not go very soon. The dementia, the patient will suffer over a period of maybe 2 to 10 years. That means providing care for 2 to 10 years is simply very difficult by an individual. That means this caregiving to a family member who is suffering from dementia, depression, the whole family should get together. The children should get together and provide care in turn. That is very essential, and whenever required, you need to take a professional help. To summarize, considering the high prevalence of psychiatric illness in geriatric population, it calls for a public health approach to provide effective treatment. Caregivers' burden and burnout is well known in geriatric population. That means the people who provide care for a geriatric population, they are in a very burnout stage. Keeping all this in mind, we need to come up with effective treatment. Of course, there are medications, and medications will show improvement up to 40 to 50% in depression. In dementia, the current treatment is only to delay the progression of illness. That means we need to come up with certain radical treatments which can help in controlling various severe symptoms. One of them is electroconvulsive therapy. As I mentioned, in depression, dementia, there are other symptoms which come into picture which will cause severe burnout in the family members. Not only that, the patient also suffers, such as aggression, irritability, agitation, decreased sleep, delusions, hallucination, disorganized behavior. All this calls for medication. Of course, you will give medication as the first choice. Suppose if it doesn't improve, even after changing 2 or 3 medication, we need to explore electroconvulsive therapy. Hence this video to see whether electroconvulsive therapy can be given safely in geriatric population. What are the indications for ECT? The primary indication is to choose for rapid control of symptoms. What does it mean? If a patient is severely ill, who is aggressive, violent against family members and others in the society. And also, if he is suicidal or else he is unable to take care of himself. In such a scenario where the symptoms are so severe, you cannot wait for the medication to act. Of course, the medication has a lag period of maybe around 2 to 4 weeks. Till then, you cannot wait. In such a scenario, electroconvulsive therapy should be chosen as a first line of treatment. However, there are secondary indications also. Secondary indications are those when you are using ECT as a secondary choice to a medication. Suppose if the medication doesn't work or refractory to the medication, such illnesses should be considered by treating ECT. Suppose if there is a partial improvement, then also you can add as an augmenting agent to the medication. And if there are treatment refractory, you can use ECT to break those treatment refractoriness. So these are the indications you should know with regard to ECT in geriatric population. And further, ECT can be used in various psychiatric illness which are severe in nature, like severe depression, bipolar affective disorder, mania, schizophrenia, catatonia, schizoaffective disorder, dual diagnosis. In such a scenario where the symptoms are very severe and you want to control the symptoms rapidly, in such a scenario, ECT works as a bone. And here you need to understand it is the severity of the illness and also the rate at which you want to control the symptoms will dictate the indication for ECT. Further, the ECT is also being tried in various other medical conditions such as Parkinsonism, delirium, neuroleptic malignant syndrome, autism, agitation, depression in dementia patient. Of course, even in uncontrolled seizures, they have been tried. And you need to understand there are no absolute contraindication for ECT. Let's look into various pre-ECT workup. That means before you give ECT, what are the investigation you are going to do? First and the foremost, you need to do a detailed evaluation of the geriatric patient. Look into the medical history, whether they had recent falls, whether they have diabetes, hypertension. Please do a thorough evaluation. Do a general physical examination, check for weight, BMI, do hemogram, biochemistry like renal function test, LFT, electrolytes. Check for dentures and loose tooth because here we are going to give ECT for a senior citizen. Invariably, the loose tooth or the dentures are common. You need to check and document it. Check for whether they have capacity to consent for ECT. If they have capacity, that means the patient has to give the consent. If they do not have capacity, of course you will take consent from the nominated representative. Do ECG because invariably elderly patient, when you are going to give ECT, it will have burden on the cardiac. Hence you need to see whether the heart is in a good condition to undergo the stress of general anesthesia. CT scan to rule out any space occupying lesion, X-ray and lung pathology if it is there you need to do, and mini mental status examination is a baseline. As I mentioned, informed consent is a must. It should be taken from the patient if he has capacity to consent. If he does not have, then you need to take consent from the NR. Consent also has to be taken during the course of ECT. And if the patient improves with ECT, and you need to take the consent from the patient directly. But however, there are certain challenges. Invariably, if the patient is severely ill, NR has given the consent for ECT. And later, after 2 or 3 ECT, if the patient improves and he regains the capacity to consent and he refuses to undergo ECT, these are the time you have to be very careful and you need to honor the wish or the will of the patient. Let's understand the ECT preparation. Invariably, before you put a patient to general anesthesia, nil oral is very essential. Minimum 6 hours prior to ECT or general anesthesia, they need to be nil oral. Oral medication can be taken in the morning 2 hours before the ECT, and it should be with the clear water and it should be with sip of water. The reason being is most of the senior citizens who undergo ECT invariably may have other medical comorbidities such as diabetes, hypertension, hypothyroidism, various other medical condition. They may be on various other medication. Should we stop those medication? Invariably, don't do that. You can give those medications with a sip of water. No need to stop any ongoing medication, such as the patient may be on lithium, maybe on valproate, antipsychotic, antidepressant. Do not stop them. You can continue the medication along with ECT. Patient should be encouraged to pass urine before ECT. And before he enters into the ECT room, please remove the dentures, jewelry, hair clips, contact lenses, hearing aids to be removed. Head bath, if it is required, please do it, because if there is a oily presence is there, that means it will give impedance, and if there is a sweat is very high, then there will be short circuit. In the sense, the electricity which is passed may not go through the brain. It will be passing through the scalp only. Hence, thorough head bath can be considered. IV cannula should be inserted into the left arm, and then you can consider giving atropine 0.6 milligram IV if you are going to think that there will be a vagal effect because of electrical stimulation. Now let's understand about the frequency and number of ECTs to be given in senior citizen. It is similar to any other adult patient who receives ECT. Invariably, it is administered 2 to 3 times per week, and the usual course is somewhere around 7 to 12 ECTs. Some patient may improve rapidly within 3 or 4 ECTs. For them, 7 ECT is more than enough. If the patient do not improve, you can give up to 12 ECTs. However, you need to individualize this ECT treatment, and there are certain patients who do well on long-term maintenance ECT. Based upon the response, side effect, you can consider continuing ECT in the maintenance phase. Let's discuss about electrical stimulus in geriatric population. As the age increases, seizure threshold also increases. That means you need to give a slightly higher amount of electrical current to get the seizure. This may be the various reasons. One is decreased excitability of the neurons and also increased skull thickness. An increased seizure threshold requires higher stimulation of through electrical current. This may cause some of the cognitive deficits. Older adults also tend to have a shorter seizure duration and also shorter slow wave phase duration and weaker seizure strength, my dear friends. Now let's understand, where should we place the electrode? Should it be bilateral ECT or else right unilateral ECT? Invariably, bilateral ECT is associated with higher emission rate, greater speed of response and remission, but greater cognitive deficit. That means invariably bilateral ECT, by default it is chosen as bitemporal. However, some of them even choose bifrontal as a bilateral ECT. However, right unilateral ECT is, you may have to give higher dosage of electrical current, that is 6 times the seizure threshold. Further, the cognitive deficits are very less, but however, it takes longer duration to improve. Bilateral ECT requires 2 times the seizure threshold. Unilateral ECT requires 2 to 6 times the seizure threshold. The individual components of stimulus package, current, frequency, pulse width, and train duration can influence both efficacy and adverse effect. The use of ultra brief stimuli, that is less than 0.5 milliseconds, particularly right unilateral ECT placement, has become very common, and also it has been found to have lesser side effect. If which one has to be chosen, right unilateral ECT or bilateral ECT? Invariably, in many of the centers, they choose right unilateral ECT in geriatric population. If the patient, after receiving around 5 to 6 sessions, if there is no improvement, they will switch over to bilateral ECT. The choice between right unilateral ECT versus bilateral ECT is based upon various numerous factors such as severity of the symptoms, what are the medications given, patient's ongoing response to the treatment, how rapidly you want to control the symptoms. Based upon that, you can discuss with the patient and the patient preference over bilateral ECT versus unilateral ECT, whether there are any cognitive deficits. Based upon that, you need to discuss and choose. Invariably, it is best to choose write unilateral ECT, especially in geriatric population. Let's discuss about the side effect of ECT in geriatric population. First and the foremost is headache, nausea, myalgia, tiredness, post-ictal delirium, that is confusional state, and mild cognitive deficits. These, whatever side effects I am discussing, they are common in the first 1 to 2 days. That is, within 24 to 48 hours, these side effects are seen. Within third day, these side effects disappear. And you need to understand, whenever the electrical stimulation is given, what is the response of the body of the senior citizen, whether they will be able to tolerate the electrical stimulus. As soon as the electrical stimulus is given, parasympathetic tone takes over. That is, vagal tone increases at the time of stimuli and seizure termination. That means on the start of the seizure and the end of the seizure, it will be vagal tone. However, in between, when the seizure is at the peak, sympathetic tone takes over. That means there will be a sudden increase in the blood pressure. And you need to monitor the blood pressure, especially if the patient is hypertensive. Hence, you need to know the cardiac strain in geriatric population who is receiving ECT is because of two reasons. One is because of general anesthesia, which you are going to give it to the patient. Further, seizure itself will increase the blood pressure. Hence, this general anesthesia is the one which dictates whether the patient should receive ECT or not. Like any other procedure, under general anesthesia, ECT carries the risk of adverse event because of general anesthesia. Let's understand. The patient may not receive general anesthesia if he has cardiac dysfunction, such as myocardial infarction, congestive cardiac failure, valvular disease, and various other cardiac conditions. In such a scenario, anesthetist will refuse to take the patient for ECT. Here, it is not the ECT is the main cause. It is general anesthesia which causes the burden on the patient. Further, certain cerebral abnormalities such as cerebrovascular malformation such as aneurysm, intracranial pressure increased, recent stroke hemorrhage are also contraindication for providing ECT in geriatric population. Respiratory diseases like COPD, pulmonary disease, asthma are also considered a risk for anesthesia. And you need to understand about the cognitive impairment. In geriatric patient, receiving ECT, the most concerning for a psychiatrist is cognitive dysfunction. Invariably, most of the patients who receive ECT in geriatric population, either they are depressed or they may have varying cognitive deficits. It may be even dementia also. Most of the psychiatrists are worried about the cognitive deficits. If the patient is already having a cognitive deficit and you give ECT, it may further worsen. And the psychiatrist will invariably worried about the malsuit practice or the patient family member going to the consumer court. Hence, they are worried and they do not use ECT in such a scenario. Please remember, if there is a cognitive deficit before giving ECT, please do document that. Discuss with the family member and give the risk and benefit of giving ECT. Invariably, the cognitive deficits of ECT includes acute confusional state, sometimes anterograde amnesia and retrograde amnesia. These usually last for 1 to 3 days, and after third day, the patient recovers well. ECT affects in the acute treatment part, not in the long-term treatment. And one need to be very careful, especially in geriatric population with regard to loose tooth, decayed tooth, osteoporosis, and spinal disc disease. The reason being is the patient who is in a senior citizen will have osteoporosis. You need to give a good muscle relaxation. If the patient has a violent seizure, he may develop fractures. Before posting a patient for ECT in geriatric population, please do a thorough evaluation with regard to CVS, RS, CNS, and per abdomen. Geriatric population may have numerous medical comorbidity that will be a contraindication for anesthesia, or else there may be a severe adverse event during ECT. Hence, my dear friend, older adult or senior citizens are at increased risk of side effects during ECT because of the medical comorbidities, not because of ECT. With ECT, the main issue will be invariably either headache or else cognitive deficits. Whereas with anesthesia, there are various side effects. Let's understand, is there any long term effect of ECT in geriatric population? There was a PRIDE phase 2 study. PRIDE here is prolonging the remission in depressed elderly work group phase 2 study, which looked into the comparison of ECT plus medication, and that is venlafaxine plus lithium versus medication alone, that is venlafaxine plus lithium. Here ECT is added and the groups are randomized, and then they did the cognitive observation over a period of 6 months. There was no difference, statistically difference between ECT plus medication versus ECT alone. That means the patient who received ECT did not have any cognitive deficits in the long run. Further, the same comparison which looked into whether right unilateral ECT with venlafaxine and lithium is relatively tolerable, cognitively safe. That means you can combine medications with ECT, that is right unilateral ECT, that too ultra brief ECT was given. Hence the PRIDE study clearly indicated two important things, my dear friends. You can combine medication with ECT. That is one. A long term, at least 6 months, there is no permanent cognitive deficits seen in most of the patients. However, now the question comes, if there are white matter hyperintensities in elderly patient, should we give ECT or not? We have done the MRI and there are multiple white matter changes. What is these white matter changes? That is, white matter hyperintensities are well known of vascular origin and invariably they are ischemic in origin. In such a scenario, should we give ECT or not? Can they cause any serious problem? There are various studies have been done and some of them have even done the literature review. In these studies, they have clearly indicated there is no difference between patient who received ECT and having depression with hyperintensity and without white matter hyperintensity. That means you can give ECT in patients who have white matter hyperintensities and psychiatric illness. Let's look into electroconvulsive therapy in dementia patient. Invariably, dementia patients may have depression as a comorbidity, agitation, aggression, delusion. In such a scenario, should we give ECT? Of course, before you give ECT, please try other important intervention such as environmental modification, behavioral intervention, antipsychotics, benzodiazepine. These can be tried. If there is no improvement in any of them, discuss with the patient's family and you can try ECT. Invariably, studies have clearly said that by giving ECT in dementia patient, you are not going to worsen the cognitive deficit. Those cognitive deficits which are there will continue. However, the confusion and some of the cognitive deficits may be there for 3 to 4 days. Here, you need to control agitation and aggression very rapidly. Invariably, the family members are at the receiving end. Now, can we decrease these cognitive deficits? There are studies which looked into acetylcholinesterase inhibitors for ECT-induced cognitive dysfunction. There was a systematic review which took into consideration of 5 clinical trials, and this study was done by Enstra and his colleagues. In this, where they looked into whether acetylcholinesterase inhibitors did they prevent ECT-induced cognitive deficits. This was one of the important review. This review of 5 studies clearly indicated acetylcholinesterase inhibitors appear to have beneficial effect on ECT-induced cognitive dysfunction. That means you can try ECT under the cover of acetylcholinesterase inhibitors, my dear friend. To conclude, although electroconvulsive therapy is a controversial treatment, but it is there and existed for more than 8 decades, my dear friend. It is oldest than antipsychotic and one of the longest biological treatment which has been time tested, have been questioned in the court of law. The human rights activist has opposed it. Many researchers have questioned it, but clinicians and other people continue to use it. That means there is some amount of evidence with regard to ECT. Of course, the current evidence clearly says that electroconvulsive therapy is one of the effective treatment available for the humankind, especially in severe psychiatric illness. Even ECT can be given safely in geriatric patient. Before you post the patient for ECT, you need to know whether the patient has medical comorbidities, whether his body will be able to take the stress of general anesthesia more than the ECT. That means whether he has medical comorbidities, which contraindicates for general anesthesia. ECT is a very promising treatment, especially in a persons with severe mental disorder, depression, violent, or treatment refractory mental illness. Thank you very much for your valuable time. Stay safe.